All right, good afternoon, everyone. Welcome to Multimodality Imaging Conference. I'm Malahfji, and today we're going to talk about Stress CMR. Here's an outline of the talk. So we're going to talk about Stress CMR and the chest pain guidelines that came out a couple years ago. We're going to cover the methodology that we use to get a good quality Stress CMR, the evidence for utilization and cost effectiveness of CMR, and we'll go over some clinical cases. In the 2021 chest pain guidelines, there's been a great emphasis on choosing the right test for the right patient. And in patients who are going to need additional findings, for example, evaluation of LV dysfunction, evaluation of presence of LV scar and extent, evaluation of viability, these are particular scenarios that Stress CMR can particularly shine. There's a favored assessment for stress imaging in general in older patients, in those who had a prior CTA that was inconclusive, and then for those who are favored for ischemia-guided management. And those are particularly going to be the higher risk type patients, such as those with prior bypass surgery, prior coronary artery disease. And there's really no particular separation or preference for the stress imaging modalities, whether it's PET or CMR or SPECT imaging, although this is highly dependent on the institutional preference and expertise. So there's a recommendation to use Stress CMR in acute chest pain, and that's a class 1 recommendation in those without known CAD, in those with known CAD and prior bypass surgery. Particularly cases also with myocardial infarction and no obstructive coronary disease on cath, and also myocarditis. And those with no CAD, the recommendation is 2A as well. And then the recommendation is overall similar, whether it's PET, stress echo, SPECT, or CTA. For those with stable chest pain, same level of recommendation, class 1 for no known CAD, class 1 for obstructive CAD, and class 2A for prior bypass surgery. But why should we favor or refer patients for MRI, and how is it that we do this? The advantages of MRI in ischemia testing are the higher temporal and spatial resolution, particularly in bigger patients, some of the patients that may have challenging imaging with other modalities such as stress echo or SPECT, where you can get what we call a wide field of view. You can essentially select any slice of the heart and get a good quality scan. BMI is usually not a limitation, and you can get very good quality studies in those patients with higher BMIs. The limitation is mainly the circumference of the patient and then being able to fit into the bore. There's no ionizing radiation. For those who need viability assessment, you don't need to wait until the next day and do a dietary preparation like you have with PET. You can essentially also evaluate coronary anomalies in those young patients who you can spare them the radiation. And you're getting a one-stop shop type of assessment looking at scar viability and LV function. There's overall a linear relationship between the image intensity on stress MRI and the contrast agent concentration. And that's particularly important for ischemic evaluation, as was covered in the prior talks, particularly when you give low doses of paramagnetic agents, which is what we do. And then time. CMR is sometimes seen as an expensive and lengthy modality, but if you actually look at the data, many centers, particularly in Europe, do stress studies in the span of 20 to 30 minutes, which is much shorter than what you would need for a SPECT study, for example. And the cost as well. There's a lot of data on cost effectiveness and the throughput of each of the labs. If you think about it, most hospitals will have an MRI scanner, and you just need the team and the structure to start doing stress imaging for these patients. So this is an overview of how we do perfusion imaging. So we're injecting the contrast, and we have one slice of the heart that we're capturing as the contrast flows through the veins into the right ventricle, which enhances, then gets into the arterial circulation and enhances into the left ventricle, and it washes out. And what we need to do here is fast imaging. We're going to acquire multiple slices every heartbeat through that period of wash in and wash out of the contrast as you inject it into the vein. This patient, for example, has a perfusion abnormality here in the inferior lateral wall, which we'll cover in a second. When it comes to the sequences, there's variations in the sequences. We can use what we call an SSFP, or steady state free precession, or gradient recall echo. And essentially, as you inject the contrast, you're going to acquire multiple slices with every RR interval. You can acquire 3 slices. That's been traditionally the way it's been done, where you get a basal slice, a mid slice, and an apical slice of the LV. But you can also get 6, where you cover a greater area of coverage, and you do those every other R to R interval. And the acquisition readout in terms of the physics can vary depending on each of the methodologies, and then there's strengths and weaknesses to each of these in terms of the propensity to have artifact and the signal to noise ratio. But here's an example. So we'll acquire stress images, and then we'll acquire rest. And here we did a 3-slice acquisition where we captured the base, the mid-ventricle, and then the apical segments. And we washed the contrast, washing through the right ventricle, then to the LV blood pool, and then into the muscle itself. And we're looking at the perfusion of the left ventricle segments themselves to see if there's any areas of delayed perfusion that fits in a coronary distribution and can potentially be due to coronary artery disease. And we'll go into this in a lot more detail shortly. Here's a potential pathway for those who are getting vasodilator stress imaging. So you're going to do initial testing of rest acquisitions. We'll get the CINES of the left ventricle, looking for wall motion abnormalities, looking at LV function. Then you're going to do either adenosine or regadenoson, and then you're doing stress imaging first, followed by another dose of contrast where where you'll do rest perfusion. In between, you will usually give venofilin to reverse the vasodilator, and then we'll do LGE imaging to look at scar and infarction. Dubunamine MRI as well as exercise MRI have also been done and continue to be done in some centers. With dubunamine, it essentially follows the same concepts as echocardiography. So it has quite good supportive data in terms of sensitivity and specificity as well as predictive value. The challenge is the side effects that come with dubunamine, the time, as well as looking at the wall motion, because you're here relying on the wall motion abnormalities and inducing true ischemia in the ventricle. And particularly with higher or faster heart rates, it becomes challenging to interpret the wall motion changes due to limitations of temporal resolution compared to echocardiography. You're also unable to look at ST segment deviations on the EKG. When it comes to exercise, it's also feasible. You have to use specific exercise equipment that's magnet safe. It's done in a few select centers, but it's gaining traction over time, and it has some potential utilization opportunities beyond ischemia testing. Here's what a potential scan for dubunamine could look. You'll do the same thing where you get rest imaging. You'll start at dubunamine, you'll increase the dose as we do with stress echo, and then you'll get short axis and long axis slices of the left ventricle at each of the dosing increments, and you'll end that with LGE imaging as well. Here's a treadmill CMR where the patient can go on the treadmill similarly as to what we do for regular treadmill stress tests, and then they'll hop on the scanner and get the study. So they'll do a Bruce protocol, 12-lead EKG monitoring, and then they'll, as they reach maximal exercise capacity, we'll do stress wall motion imaging, followed by perfusion, and then rest and LGE as well. Notice that the time that's needed to do this is much longer, whereas if you look at the vasodilator stress test, you could really do it in 25 to 30 minutes, particularly if you're just focused on ischemic assessment. Here's an example. So I don't know what you guys think, but this patient looks more to be a healthy volunteer rather than someone who needs a stress test. But they'll go on the treadmill. The techs, the better the techs and more versed in doing this, the faster they can be. And then you'll have their receiver coil put on, and you'll have the setup for the scanner already planned out so that it starts quickly. And as you know here, time is of the essence, essentially. You can also do an exercise ergometer type bicycle, and then this also allows you to do this while the patient is still in the bore. Let's talk about interpretation. So this is one of the landmark studies that really established many of the ways that we look at studies nowadays. And it essentially starts by looking at delayed enhancement, or LGE, imaging to actually identify, does the patient have a prior infarction or not? If they have a prior infarction, then you establish that they have underlying coronary disease. If they don't, you're going to do your stress perfusion, and you may still do the stress perfusion after you establish that they have an infarction to look at peri-infarct ischemia or ischemia in other vessels. When you see abnormalities on the stress perfusion, you're going to compare it to rest. And here is a particular key difference that we have against, or as opposed to SPECT imaging, where if you have, where the scenario is if you have an actual perfusion defect that remains on both stress and rest, then that could be actually an artifact. Again, different than what we have on SPECT imaging. Whereas if you have a defect that shows up on stress, does not show up on rest, then that represents ischemia. The reason is because we're doing stress imaging first, you had actually given the patient contrast already, and that contrast actually stays into the LV as you do the rest imaging. So you're supposed to have some enhancement already. When you follow this algorithm in this particular study, they found that combining the SCAR as well as the perfusion assessment had a very high sensitivity and specificity and overall accuracy of 88%. Whereas if you rely on just the perfusion alone, the overall accuracy is lower, and the specificity particularly is what suffers. Here's some of the data to highlight how critical this is, or how strong MRI can be in assessing ischemia. This is an animal model study that also looked at a subgroup of patients with coronary disease, and essentially used older generation SPECT imaging to compare the ability to detect limited subendocardial infarctions on MRI versus SPECT. And you have the animal model here as well. In this particular study, they were able to identify 92% of the segments with a limited subendocardial infarction, whereas SPECT only identified 28%. And in the group of patients, in those segments with an existing subendocardial infarction, up to half of them were not detected by SPECT. So this also adds to the strength of this algorithm because it's allowing you to detect CAD at sort of a preliminary step prior to you just relying on perfusion. So let's cover some of the randomized control trials and observational studies that support the case for using CMR. So this is one of the first studies of looking at stress MRI, and this is the CE Mark trial. Established the diagnostic accuracy of stress CMR against invasive coronary angiography as the reference, and compared it against SPECT. It included patients with angina and at least one risk factor for coronary disease who were scheduled for all three tests essentially. Sensitivity of CMR was 86%, specificity 83%, with a very good positive predictive value and an excellent negative predictive value. The sensitivity and negative predictive value of CMR were greater than SPECT. The positive predictive value and specificity were not different. I noticed that the advantage of MRI against SPECT, and I'll also say the caveat that this was an older generation SPECT assessment, CMR was essentially superior in all of the subgroups, whether it's a 70% threshold for coronary stenosis, 50%, and also those with multi-vessel disease, 2 or 3 vessel disease. The CE Mark trial number 2 followed, and this was more of a study looking at guided care of CMR versus perfusion imaging versus the NICE guidelines from that time, which was a prior version to what we have now. And it looked at unnecessary invasive angiography, which was significantly reduced by using either the Stress CMR or the perfusion testing group compared to the NICE guidelines, without any decrement in adverse events. In terms of prognostication, the SPINS trial, as well as this particular study from the SCMR registry, have really highlighted the strength of stress MRI in prognostication of CAD and unknown CAD patients. And this was a very large study of more than 9,000 patients with a very large number of events that we participated in. And it shows that those with an abnormal stress CMR can be prognosticated to have a worse event rate, whether they have no known history of CAD, whether it's those with history of CAD, normal EF and abnormal EF, and also whether they have a prior infarction versus not. The SPINS trial also looked at similar questions, and this was a retrospective study of 13 centers that included patients who were evaluated for chest pain with stress MRI. It targeted a follow-up of at least 4 years, and the primary outcome was vascular death and non-fatal MI. I noticed that the presence of ischemia and late gadolinium enhancement was associated with the higher or with the highest event rate, but also presence of ischemia without infarction also differentiated those against those who do not have either ischemia or scar. And this was also persistent, or the findings were overall consistent, whether you looked at the patients by extent of ischemia. So blue is no ischemia, red here is mild, and then black is moderate, and then the purple is severe. The MR Inform study looked at FFR guided strategies versus stress MRI. And this was building on the hypothesis that guiding management of patients with stable angina, intermediate to high risk of coronary disease, is non-inferior to invasive angiography by FFR. And this is the randomized controlled trials that randomize patients to either invasive angiography with FFR all vessels and revascularization as appropriate, versus stress MRI that's done and interpreted the same way that I alluded to. And the composite endpoint was all-cause mortality, non-fatal MI, and then revascularization at a vessel targeted at the index revascularization procedure. The rate of revascularization was slightly lower in those who went through the MRI-guided strategy versus FFR-based strategy. And the outcomes were the same. Notice the superimposed lines. And this was persistent up to 12 months, and I believe it's been extended, and extended outcomes were also published. So let's go through some cases. So like I alluded to earlier, we're going to look at the cine, the LGE imaging, and then we're going to look at perfusion. And I'll have some cases that highlight why we do that also. So this is a 56-year-old female with exertional chest pain. She had normal LV ejection fraction and normal wall motion. And when we do her LGE imaging, we find that she has no scar or infarction. So here's stress at the top and rest at the bottom. And I hope this projects well. But we don't see any perfusion abnormalities at stress in either of the slices. And if you think about it, once you have no scar, normal LV function, and normal perfusion, you're essentially done. You've evaluated the patient as not having CAD. The rest acquisition here, which some centers advocate that you don't need to do it, helps you in identifying artifacts. So let's say you find a small abnormality that doesn't seem to correspond to a coronary territory, or you're not sure, and you find it on both the stress and the rest imaging, then you could conclude that that's actually artifact particularly because you haven't found any LGE in that segment. Yes?
If you go back to this,
Mm-hmm.
in the middle, I mean, you could maybe repeat it under the microphone. In the middle, I
Yes.
see a rim of blackness.
That here?
Yeah, exactly. That's what you guys tell us. This
Yeah.
is a defect.
Yes.
So why are you dismissing it without highlighting?
So here, there's a bit of a small area that is not getting full perfusion from the first couple of slices. But the way that we go about this, and let me try to, oops, because this doesn't let me, unfortunately. What we do is that we actually go frame by frame, and to actually call a perfusion defect, we want it to actually involve more than 1 pixel width of the actual thickness of the segment, and it has to persist through multiple beats. So this is an artifact essentially that you don't have to have it both on stress and rest, but to balance the sensitivity and specificity of the reader, you have to show a defect that persists through multiple beats and extends beyond just one thin line of the endocardium. There's also a temporal resolution issue here. So because we're acquiring each of the beats over the span of, let's say, 20-25 seconds, we actually use a motion correction algorithm here to stabilize the heart motion. But obviously that's not going to be perfect. And if the patient has a PAC or a PVC in between, this is part of the reason why you see a little bit of motion. The last one is the breathing also.
That motion is just respiratory motion there.
Yes.
Because these are all
Yeah.
real-time images. These are taken over 150 milliseconds.
Mm-hmm.
So this is taken as a snapshot
Mm-hmm.
of the cardiac cycle, basically.
Yeah.
But yeah, what you're seeing, that black pixel there, that's a susceptibility artifact. It's just one single pixel. So that's, that's one, I mean, that's a common known artifact, so.
Yes.
For my eye to detect it, it has to be more than 2 pixels.
You have a very sensitive eye. Don't underestimate your eye.
So this patient had a cath and didn't have any obstructive lesions. Now let's talk about this case. 60-year-old man with a prior bypass surgery, exertional chest pain. As we look through his LGE imaging, notice that there is a limited subendocardial infarction here in the inferior wall and the inferior septum that extends also to this upper mid-segment, but we don't see much of in the way of infarction distal to that. So we've established that he has CAD, which we know by virtue of him having prior bypass. So let's look at his stress perfusion. What do you guys think? Let me, I wish this would let me. So notice that there is an ischemic defect that involves a larger segment in the inferior septum, inferior lateral, and inferior walls. And notice how it extends into the mid-segment of the endocardium. Notice how it persists throughout multiple cycles and extends into a coronary territory, so the basal, the mid, as well as towards the apical inferior segments primarily. When we look at stress, we don't see much in the way of a perfusion abnormality.
So
Do you guys agree?
It's usually optimal to look at the stress next to the delayed enhancement.
Mm-hmm.
You've got delayed enhancement that tells you what's infarct, and then you really want to just compare that to the stress perfusion.
Yes. So the question here is, you have someone with pre-existing CAD, pre-existing infarction, and an associated perfusion abnormality that, like Dr. Shah was saying, you have to compare the extent of the perfusion defect to the extent of infarction to decide if there is peri-infarct ischemia or not. And here, because it extends into much further down the ventricle, we would conclude that there is a pre-existing infarction with coexisting ischemia. And this is how the perfusion abnormalities would look also. And he had a cath that showed an occluded RCA, essentially. Let's go through this case. So this is an 86-year-old man, heart failure with reduced EF. He's referred for ischemia/viability, and there was a question of low flow, low gradient AS as well. So we'll start with the LGE sequences and notice that there is a small limited infarction in the inferolateral wall that extends towards the mid-segments. And here's the perfusion imaging. And ignore the arrows. These are supposed to show up later. What do you guys think? So I would say a sizable perfusion defect that also extends in the inferolateral wall as well as a small portion of the inferior wall through the base, the mid-segments, and towards the apex as well.
What's that septum?
Let's see.
I mean, where do you see
This
it
here?
demarcated all the way?
You're referring to this line here?
Right.
Well,
This is the same.
No, this is
The same one.
basal septum, right? Remember the septum, that area, you will have a perfusion.
the Dr. Zak, be similar to echo, you know, we try not to call the inferior septum because otherwise everyone will have an infarction. And here's his cath. So you may have been right actually, because he has a severe distal. You know what, let me rephrase. You were definitely correct. There's a severe distal RCA lesion that may have caused some of the ischemia in the inferoseptum, and there's an occluded circ as well, or subtotally occluded circ. Now, what about this case? 30-year-old man, abnormal EKG, chest pain on exertion. Looking at the cine, what do you guys think? So HCM, there's asymmetric hypertrophy. Is there an LVOT obstruction, would you say, or no? And what type of HCM is it? Yeah, we don't see any, at least not at rest. He has that reverse curve pattern. Now let's look at his LGE. What do you guys think of this? Normal, abnormal, CAD scar, non-CAD scar? Let's ask the MRI fellows. What do you guys think? Anish? Yeah, so there's patchy, non-CAD, LGE, particularly in the hypertrophied segments, notice in the basal septum, all the way down here in the inferoseptum, the anterior wall where we saw a large area of the hypertrophy as well, and all the way down here. Now, does it appear to be coronary mediated or non-coronary mediated? And why not? Mm-hmm. Yes, yes. So here's his perfusion. And notice he has a perfusion abnormalities predominantly in the same distribution as you have the LGE. So primarily in the basal septum, in the anterior wall, and then here in the apical septal segment as well. So is it epicardial disease? Is it microvascular disease? Neither? Can you tell? Yeah, so I mean, HCM patients will often have perfusion abnormalities, and that's been, seen on stress echo, SPECT, PET, and they are known to have microvascular dysfunction due to microvascular damage with the myocyte disarray, but also luminal abnormalities in the microvasculature. can you definitively exclude epicardial disease? I would say you would have to go by the pattern of the defect, if you will. Notice that it has kind of that same patchiness that you have for the areas with LGE, and you would have to look at the coronary distribution. Unfortunately, that's not always very feasible, but more likely than not, particularly on the patient, based on the patient's pretest probability, this is more likely to be related to microvascular disease. And I'll show you another case that highlights this also.
You know what's interesting to
Mm-hmm.
me is that the big area of defect that you had on LGE
Mm-hmm.
has decent perfusion. Like if you go
Yes.
back,
Yes.
if you go, you had a big chunk
Yes.
that is hiding behind your arrow.
Mm-hmm.
Right? On the left side, left upper, on the LGE.
Yes.
Here you go.
Yeah.
You got a
Yeah.
big chunk of, right,
Mm-hmm.
that has decent perfusion.
Yes.
And you put perfusion, which is a bit disconcerting.
What-
Is that normal in that area also? Remember, the slices here are mixed, right? So the middle slice is actually more basal than the left-hand side slice.
I would say the matching of the slice, but also the resolution of the perfusion images is also lesser so than we have for the delayed enhancement images. But usually these would match. You have to match it slice for slice.
The middle one here, you can pause it.
It just bring a question for you guys, you're the expert on this, is if I have a big area of LGE positive
Mhm.
replacement, and if I give a perfusion, do I see still quite a bit of perfusion in that area, yes or no?
So it depends on what the LGE it is. So if it's LGE that's dense from an infarct, if it's LGE that's dense from an infarct, then you're going to have a perfusion defect as well on stress. This case, you look at it, it's a large area, but if you go back to the LGE, look at the intensity of the LGE, right? It's kind of it's intermediate signal intensity, because that area of LG doesn't mean that all of that is complete destruction of monocytes, right? That's why it's kind of patchy. It's got an intermediate signal intensity. So there still is viable myocardium in that area. This is
Yeah.
non-ischemic LG.
So it's intermixed, normal and healthy, and
But like in an infarct, like where there's a dense pattern of LGE,
Mhm.
there you'll see a perfusion defect as well.
in the same area of LG. Yeah. The other very interesting finding, particularly in younger HCM patients, is over time they develop more scar, particularly as they are getting more hypertrophied, and the presence of the perfusion abnormality can actually, well, it's been shown to be associated with further progression of LGE. And we have some cases where a younger HCM patient will have perfusion abnormalities, minimal LGE. They get a follow-up scan, and the areas where you see the perfusion abnormalities develop more and more LGE over time as well.
Do you ever quantitate these perfusion? You have a perfusion curve. I mean, we used to do quite a bit of this in contrast echo in the early days, and was not that helpful. Looking at the time intensity curve,
Yeah.
because, I mean, interestingly enough, I don't know if the contrast, but in contrast echo, there's lingering of the perfusion agents in the venous system in addition to the arterial system.
Mm-hmm.
So
Yes.
that's why
yes.
it's not a one-to-one correlation.
Yes, and there is that capability, and it's been looked at more and more rigorously over the past few years. There's now fully developed sequences that will fully quantitate automatically. It used to be that we would have to draw out the region of interest over the areas of interest and get a perfusion curve at stress and rest and compare to get what we call a semi-quantitative CFR essentially. And I'll cover that in a second. We have some studies on that also.
Getting back to the question,
Mhm.
with regard to, do you get then venous contamination as well? The one thing with the kinetics of gadolinium, a lot of the gadolinium gets extravasated out, but it still will be some in the venous system. So there could be some, but I don't think it'll be it'll be lesser of a magnitude, I think. Whereas I think with the echo contrast, it doesn't really extravasate out into the myocardium.
Right. So this case, 74-year-old man, dyspnea on activity, syncope, echo with LVH. What do you guys think of the LGE acquisition? Anish? Well, there's an artifact, but what about here? There's no artifact here.
It's as wide as the cat.
Yeah. So, Dr. Zogby.
Most likely, it seems like it's almost everywhere.
Good. Yes. Yeah. I'm glad you said that. So yeah. So there's diffuse delayed enhancement, non-coordinated distribution, mid-myocardial predominantly, and it involves the whole LV and actually also the atria, potentially also the RV. So fairly consistent with amyloidosis. He had a stress MRI as well. What do you guys think of this?
It's more of like subendocardial circumferential perfusion.
Yes. And do you think he has underlying epicardial disease as well? So this is a scenario that we see not very commonly, but these patients can have a perfusion abnormality in the areas, particularly in the amyloid deposition. And he actually ended up getting a cath and not having any epicardial disease. Key factors, same as prior, looking at the perfusion defects and seeing whether they correspond to a coronary distribution or not. Even someone with multivessel disease or left main, I can't say I've seen someone who has, total body perfusion abnormalities of the left ventricle. Now here's that case that I was.
From a technical point of view, can you display these in long axes of the ventricle, or you basically have to use those three short axes?
We do so now. So we do 6 slices to cover the short axis of the LV, and we do 1 additional 3-chamber long axis slice also. And that helps us also in the interpretation.
2D acquisitions, not a 3D, you can't reconstruct it.
No, I understand.
Although I have to say, interpretation-wise though, I feel like the short axis is usually sufficient. But having that long axis additional view, I think adds to the confidence of reading. Okay, so here's another patient. Asymmetric septal hypertrophy, SAM, LVOT obstruction. He's 65, has exertional chest pain, dyspnea. I'm not going to show you the LGE first, but this is another reminder to actually go by the LGE. So he has a perfusion abnormality. I'm going to go a little bit quicker in the interest of time. Notice that it goes here in the anterolateral wall. There's potentially a perfusion abnormality as well here in the infroseptum, inferior wall. And then apical anterior, apical lateral, apical inferior. So multiple perfusion abnormalities potentially in multiple territories. If you compare them to the 30-year-old we had before, notice that they don't have that patchiness type appearance. But the key question is, or the key aspect to all of this is, you have to go by the LGE first. So notice he has infarction in the apical inferior wall, and then he has a limited infarction here in the anterolateral wall, and here's that infarct in the apical inferior segment. So if you go by the traditional algorithm, based off of this, you did conclude that he has underlying CAD, although he does have hypertrophic cardiomyopathy and he's allowed to have microvascular disease. And we've essentially concluded that, yes, he has ACM, but he also has underlying CAD with ischemia in the diagonal and RCA territory. And he had a cath that confirmed that actually. So he ended up getting a myectomy and bypass surgery. And then this is the later development of perfusion testing with quantitation to get myocardial blood flow in mLs per minute per gram of the left ventricle. And like I said, this is now fully automated where at the scanner, the algorithm can be derived and give you per segment results for rest and stress myocardial blood flow. It hasn't been as rigorously studied as other methods, but I think it adds to the diagnostic accuracy and confidence in many cases. And the key aspect is recognizing that it's a post-processing or it's a derived map that is subject to the issues of other mapping techniques. So if there's an artifact, if there's breathing motion, if there's arrhythmias, you can end up with wildly wrong numbers if you're not careful. In this particular study of 150 patients who had stress MRI as well as invasive angiography with quantitative analysis, they showed that using the quantitative analysis techniques on top of the visual analysis that we usually do did improve the detection, particularly of multi-vessel disease. We can also derive the traditional CFR values by CMR by looking at coronary sinus flow and quantitating coronary sinus flow both at stress as well as rest and getting a ratio. And in this study, this was found to have additional prognostic value on top of CMR findings and clinical risk factors.
That's a total heart.
Yes, so here you're getting your total coronary, whereas in the more recent studies, you're getting
I think this is actually much, if you go to
the coronary sinus.
I think this is actually much more reliable way to measure.
You're getting a global assessment.
Trying to do
Yeah.
kind of mathematical modeling of what's happening at the tissue level and then deconvoluting the curves and all of that.
Yes, yeah.
This is essentially two measures. So what's a measure of flow
Mhm.
in the coronary sinus at rest?
Mhm.
What's a measure of flow in the coronary sinus during stress?
Yes, yes.
Why did you choose the coronary sinus?
With the,
Everything comes back to the coronary sinus. So
So
that's the
you're-
largest vessel. Right, it's one single vessel, you can measure all the flow that goes to the heart.
Mhm.
that's a total heart thing, you know. You would be more specific and less sensitive. But
This
if
is
you have a
for
small area.
global- This is for global CFR.
I know.
Mhm.
You still have the individual, values for pixel by pixel, but I think that, again, a global measure, technically that's the most reliable measure. A
Yeah,
global
but
measure.
rarely, if ever, you're gonna have a global CFR depression. Because, the good areas will increase your coronary flow reserve and the bad areas may be flat. So the question is, how sensitive are you gonna be? I bet it will be specific, but not sensitive.
No, I don't think you use this. I think what I'm saying is from a technical standpoint, that's the one that's the most reliable for a global CFR assessment. As
Mhm.
opposed to trying to look at all of the myocardium and come up with a global CFR assessment.
Mhm, mhm.
It would be interesting to see regionality of
Yeah.
your flow curves,
Mhm.
how regionally they are different. And if they're quite different, obviously you have to take each region's its own normality to define that normality curve.
Right, yes, yes. All right, so to conclude, CMR is a powerful modality for a comprehensive, non-invasive ischemic evaluation, and you're also getting a detailed assessment of the aorta, the valves, the other ventricles, beyond what we have with other modalities in many scenarios. It's now recommended and fairly equivalent to other modalities in most scenarios. It is particularly preferred in patients with MNOCA, suspected myocarditis, microvascular disease, or INOCA as well. I had to skip some of the cost effectiveness data, but in many studies it's been shown to actually be more cost effective compared to other modalities, while also being non-inferior in terms of events and tested in randomized studies. And then great potential with the caveats for quantitative perfusion, like I alluded to earlier. Thank you.
Well, why would it be preferred in microvascular disease?
For
Because, you may not see any perfusion defect, and I'm not sure you're able at this time, unless you look at coronary flow, to tell me about flow reserve.
So the preferred statement, I think, doesn't include PET in that question. And there is actually, I think some area of lower clarity or unclarity if patients with isolated coronary microvascular disease will have perfusion abnormalities versus not at all. Because like I showed, for example, in the amyloid patient, he did have a perfusion abnormality throughout. Whereas others will say, oh, CMD shouldn't give you a perfusion abnormality. But I will argue that with these quantitative methods, at least in the research that we have, they've actually been quite well validated against even microspheres or reference standards for blood flow assessment. So should you do a PET versus CMR for someone with suspected microvascular disease? I think has not been directly answered. The experience has been more with PET more recently, but I think these measures on MRI that we get are also quite validated. You agree with that? Yeah.
Thank you for the wonderful talk.
Do we have any data comparing stress CMR versus stress PET?
So there's the Pacific trial that Dr. Almala always covers, where patients had all imaginable tests done. And the PET was not rubidium PET, but it was O15 water PET. And the numbers were very close to each other, whether it's stress MRI or stress PET, they both had the highest accuracy. I think numerically the number for PET was a little bit higher, but I think in terms of sensitivity, they are the two highest sensitivity modality in terms of non-invasive assessment for CAD.
Just looking at numerical numbers, the
Yeah.
final concluding statement in the Pacific trial was
Yeah.
that there was not a difference,
Right.
right? I mean,
Yeah.
You can't,
Yeah.
there
Yes.
was no difference. Yeah.
Yes. Yeah.
You get like a coronary flow reserve with the PET scan, probably then. That can be like another advantage, right? You get a territorial coronary flow reserve with PET scan.
Well, but like we showed here, you can get that on MRI as well. So we're not reporting it routinely, but we actually do get that data. And I think, really it comes down to the type of patient you're seeing. If you have a patient with a cardiomyopathy or someone who has, multiple questions you want to answer, they have MR, they have an EF of 30%, you want to evaluate the etiology of cardiomyopathy, assess for ischemia, and look at MR severity, MRI is a much better test than PET. And, I think in the current world, you have to pick the best test for the right patient. If you have, let's say a 50-year-old with a BMI of 40 who can't lay flat because their back hurts, and you just want to look at ischemia, then I would send them for PET because, the MRI portion still takes a little bit longer in terms of how long they have to lie down for and their cooperation with the test.
Yeah, I mean, to get to your comment you're asking about, to say, okay, can I look at regional or per segment flow reserve?
Mm-hmm.
You can do that. There's several, you can do that with many different modalities. The question again comes down to what is the level of the accuracy, right? And again, I mean, that's where I think, because we've got the sequences, you can do it as well. I think you want to get comfortable with it, but you also have to be realistic about it. When you're trying to look at the myocardium, you're trying to look at a signal intensity curve within the myocardium and then try to deconvolute that curve. Whatever modality you're using to do that, right? I mean, they're all using the same basic approach.
Yes.
There's potential for noise in that, okay? And so that's what I'm saying is that you have to be careful about not just kind of hanging your hat on some numbers that come out, but look at kind of what's the methodology by which this is derived and be cautious because you could have false positives.
Yes.
You have to see the data. I haven't seen the data.
For the
quantitation
Yeah.
of coronary flow reserve.
Yes.
And the regional heterogeneity, what do you expect? I mean, all these areas, looks like you have
The quantitative methodology, so somebody has to take a look under the hood, see how well it works, how regional it is. And
Can
if
I
it is
show-
too regional, becomes problematic.
So this study I went over quickly. It did cover that because it looked at regional quantitative analysis of the perfusion maps.
In a normal, what do you
And
expect?
I mean, I think there's been other studies that followed, and this is a 151 patient study, so I wouldn't necessarily take it as a reference standard.
Detection of disease, I want to know the raw data of
Mm-hmm.
coronary flow reserve or myocardial reserve
Mm-hmm.
based
No, so,
on
I mean,
based on the curves. You see
Yeah,
what I mean?
if you go back to this,
This map does give you that. It tells you, 2.1 or 1.8 and 1.5.
I understand,
Yeah.
but I want to see the data and see how heterogeneous it
Yeah.
is in a normal population to start with.
Ah, I see what you're
You
saying.
understand?
Yeah.
So that then I can take this and say, well, does it work in single, multi-vessel disease,
Mm-hmm.
right? I mean, that's how you're gonna dissect it.
Yeah.
Because I know we've done a lot of work for contrast echo and that, but I would love to see it since now you have a decent signal and you have almost automated ways of doing it.
Of doing it. Yeah.
And you
yeah.
see how much noise. I mean, if there's a lot of noise, you can't use it.
I think it's certainly worthwhile to look into some more. Yeah. And we have it available to us, but as you know, we've been doing aortic and mitral regurg research a lot more often than stress imaging. But yes, yeah, we'll add it to the list of items to look at. All right. Well, thank you, everyone.